without further ado, I am one of the clinical endocrinologists at Georgetown. I've been at Georgetown for 20 plus years, did my fellowship there, so I really feel like, you know, that's been my home for a long time. So we are talking about diabetes management today. That is, of course, at least 50% of endocrine patients. Diabetes is extremely common. There is some statistics here. I think this 22 million, it's now over even 25. So the number keeps changing on almost a monthly basis. So number of people diagnosed, as well as large percent of people that are out there but still undiagnosed. And then the huge category is this pre-diabetes category. And we'll talk about more what does the pre-diabetes means. Just to illustrate this better, lifetime risk for anybody born after 2000, 1 in 3 for developing type 2 diabetes, for Caucasians, 2 out of 5 for African Americans and Hispanics, and for Hispanic females, it's almost basically it's a 50%, 1 out of 2. So very, very common problem. As my daughter put it when she was very young, she said, well, it seemed like you'll never run out of business. In 2011, the mean age of diagnosis was 54. So it's not only disease of older people, there are younger and younger people with diabetes. And one very important thing for your real life as well as for your exam, I've seen this question, diabetes increases the risk of heart attacks and stroke by more than 3-fold. Okay, so the other things you need to know is that overall the risk for death among people with diabetes is about twice of the people without diabetes. And extremely important that the diabetes is a leading cause of blindness, end-stage renal disease, and non-traumatic foot amputation. So if you are asked on your exam what is the leading cause of people going on dialysis, number 1, diabetes, number 2, hypertension. Of course, majority of diabetics also have hypertension, so usually it's combined. This is not the election map. This is the map of obesity on the top, and then diabetes below that. And the darker the red, the more diabetes and more obesity. And without any, you know, further talking, I think it's pretty obvious that diabetes and obesity, they are marching together. And that should not come as a surprise to anybody. There are some states that now have already more than 10% of their population with type 2 diabetes, and those are the same states where, you know, over 30% of people are obese. So not just overweight, but obese defined as a BMI more than 30. This is one of my favorite slides, but also very, very important. I use this slide when I teach the pathophysiology, pharmacology of type 2 diabetes. The reason why I emphasize this because it illustrates nicely progression of type 2 diabetes and decline in islet cell function that occurs with time. So if this, you know, if you see on the x-axis, you see the number of years from the time of diagnosis, and this is on the y is the percent of islet cell function. It's clear that with time there is a progressive loss of islet cell. So if we go to roughly you know, time 0, which is here, which is at the time when diabetes is diagnosed, you can see that at least 50% of those beta cells are already lost. So it is like you renting a car and somebody gave you a car that already has, the reservoir is half empty. So you should not be counting on that car making the same trip as if you got it with a full reservoir. So same kind of idea here. So, you know, the clock starts ticking from the time of diagnosis, but really the loss of beta cells starts way, you know, before that. And usually that can be 3 to 5 or more years before. And that is the time where if you look for those patients, you can find them in pre-diabetes stage or impaired glucose tolerance stage. The slope of this curve, it varies from person to person. Some people have very sharp decline in their islet cell function. Some have very slow. So yes, not everybody with type 2 diabetes eventually ends up being completely insulin deficient and needing insulin, but a large percent of people do become insulin deficient. The other thing about the progressive loss is when you are talking to your patient, to emphasize that diabetes is progressive disease, meaning that there is a time factor. So they, you can procrastinate and they can procrastinate and wait forever. This is taken from the Diabetes Care, the American Diabetes Association guidelines, how to approach management of hyperglycemia, and primarily focusing on the A1C goal. So if I ask you, what is the A1C goal for diabetic patients? And if you say less than 7, well, you will be partially right. And the reason why I say partially, because there used to be an answer, or some people advocated even less than 6.5, but over the years the ADA and the diabetes expert came to conclusion that we should try to individualize the goal and make it as more patient specific as we can, because of different factors. So for example, the life expectancy. If you have somebody, unfortunate patient with cancer that has a short life expectancy, well, there is no need to aim for that A1C goal less than 7. The patients that have other risk factors associated with hypoglycemia, patients that, the newly diagnosed, we should be as aggressive as we can. Patients that have long-standing diabetes, usually we can be a little more relaxed. Age is another factor. Somebody that's 80 years old does not have to have diabetes less than 7. So I'll give you a quick rule of thumb. If patient is less than 70 and overall has no other reasons for not, a contraindication to strict glycemic control, age less than 70, A1C less than 7. Once when they are over 70, let's say they're between 70 and 80, that goal can relax a little bit. So I usually tell patients it sort of starts mimicking their age. So if patient is 75, I may tolerate A1C goal up to 7.5. Once when they are over 80, then we start approaching maybe between 7 and 8 A1C goal. And what about those patients that are 90 and above? Well, then we let them eat the cake. They can kind of not exactly do whatever they want, but clearly we can relax quite a bit when somebody is over 90. So I just want you to kind of not to get, only focus on that one number less than 7. I like this little chart that I have this in the clinic. It helps to convert the average blood glucose to A1C, because often those glucometers will give the average blood glucose. So patient may say, oh, my average blood glucose is 154. Okay, well, that means the A1C is 7. And some labs have started actually reporting this as well. In addition to A1C, they will give you what's the estimated average glucose. So why do we have so much diabetes? Why did I say, well, endocrinologists will never run out of business? Well, those are pretty clear reasons. If you have not seen this movie, and some of you that are really young may not, because this movie came out now, it's been probably at least 15 years, I think. I was maybe in my fellowship or somewhat later. So it's not, I'm sure it's totally free and available on Netflix or whatever platform you watch, but it really nicely illustrates what happens when somebody is indulging in a junk food. In this case, the experiment that this person did, intentionally eating McDonald's for breakfast, lunch, and dinner whole month straight. So it's a kind of documentary. So please watch that. You are aware that obesity is increasing. I already talked about that. We are less physically active. Patients, population is aging. Diabetes does increase with age. And then we have more of the different ethnic groups that have high prevalence of diabetes, not just the Hispanics, but also Asians, particularly people from India, the people from Middle East, there are areas in the world that really has a very high prevalence of diabetes. So the question is type 2 diabetes preventable? Well, the answer is to some degree. Genetics clearly plays the role, so we cannot change in genetics. However, about 9 out of 10 could be avoided if the patients would keep the weight under control, exercise, eat healthier, won't smoke. And we have a clinical trials that support the prevention of type 2 diabetes, risk reduction as much as 60%. And the best way to do that is not necessarily taking medication. This has been looked, especially in diabetes prevention trial. The best way is what I just said here, keeping weight under control and exercising. So the answer, if diabetes is preventable to a large degree, can be either prevented or delayed. The onset can be delayed, which is also important. But the key is patient needs to start early, before they reach the point of no return. Once when they lose 50% or more of their beta cells, then it becomes difficult to get back on track. So what really causes type 2 diabetes? Well, we know about the insulin that has main role in glucose lowering, and we already established that type 2 diabetes is really a combination of genetic and lifestyle factor. Clearly, type 2 diabetes develops either when the body is unable to produce enough insulin and becomes resistant to insulin. If the patient is only resistant to insulin but still makes insulin, they are usually in pre-diabetes stage. So kind of, if somebody wanted to write a really difficult test question, if they ask you, do patients with insulin resistance necessarily develop diabetes? The answer is you have to have a beta cell deficiency in addition to resistance to develop diabetes. Okay, so how do we diagnose diabetes? There are different ways to do it. One way is to look at the fasting blood glucose. So what is the normal fasting blood glucose? Any glucose less than 100 is normal. Any fasting blood glucose above 100 but less than 126, it's called impaired fasting glucose. And then fasting glucose above 126, confirmed on 2 occasions, that qualifies as diabetes. The other way to diagnose diabetes is to do oral glucose tolerance test by giving a patient 75 grams of glucose, checking glucose at baseline, and then 2 hours after. If 2 hours after glucose is more than 140 but still less than 200, we call that impaired glucose tolerance. And if it's more than 200, that is diabetes. The third way is based on a random blood glucose more than 200 with symptoms of diabetes, symptoms primarily being polyuria, polydipsia. The fourth way to diagnose diabetes is by doing A1C. This happened to be the most common way because it's sort of convenient, easy, but actually that was not recommended or adopted officially as a way of diagnosing diabetes until 2009. So we only been officially doing that for just over 10 years, because especially some prior A1C tests were more prone to influence of some hereditary red blood cell diseases and abnormalities. Now that's been largely corrected. So A1C of 6.5 or greater is used for diagnosing diabetes. The A1C reflects the last 12 weeks of the glycemic control. Since it's the sugar attached to red blood cells, of course, it is still prone to some problems if the patient has had either blood transfusion or severe anemia, for example. Just to recap, what are the common diabetic complications? We usually divide them in the micro and macrovascular. So the small vessel complications are retinopathy, nephropathy, and neuropathy. And the large macrovascular complications are stroke, heart disease, and peripheral vascular disease. This is important to know, and I like to, I think when you are evaluating diabetic patient, either on an inpatient or outpatient setting, when you're taking a history, you should keep this in mind. And you could start by, you ask the patient, first of all, establish whether they have type 1 or type 2. That's very important. And then you state how long they had it. And then you can say patient has known following complications of diabetes, and you list any of the complications they may have. So just to show a couple of pictures, since they say picture is worth 1,000 words, this is how the normal retina looks like, and this is a classic example of proliferative retinopathy. I did see this on the USMLE on internal medicine boards. The eye exam, although that should be done at every diabetic visit, in reality, all diabetics should really see eye doctors. I personally defer the eye exam to eye doctor, because to see the to do good fundoscopic exam, you need to dilate the eyes, and that's usually not accomplished in a regular clinic setting. Here showing some foot tissue. This is somebody with what we call a Charcot joint. That's one of the complications of diabetic neuropathy. Unfortunately, any of you that has spent any time on an inpatient service and taking care of any limb service patients that have diabetes have seen patients with those complications. It's very unfortunate because it can be largely prevented. To refresh your memory, what are the goals for glycemic control? We already talked about A1C less than 7 in general, but the goal should be individualized. Preprandial blood glucose 90 to 130 and postprandial less than 180. 180 is as easy to remember because 180 is a kidney threshold for glucose excretion. So once when the blood glucose goes above 180, definitely when it reaches 200, a patient starts urinating more, and then because they urinated more, they are thirsty. So those classic symptoms of polyuria and polydipsia, they usually don't occur until the blood glucose reaches 180. That's why you can have somebody that comes to you, denies any symptoms related to diabetes, and you do their A1C, and A1C will be elevated because if they are not, if they are just around this threshold, they are not going to have many symptoms. So on average, diabetics go for 3 to 5 years with hyperglycemia before they are diagnosed. 3 to 5 years before diagnosis is made. So as a general rule, when we are, trying to lower the glucose, we try to normalize the fasting glucose first, and then we target postprandial glucose. And you will know that postprandial glucose are not at goal because if the preprandial values are at goal, and if the fasting is at goal, but A1C levels are still elevated, that means the patient is having postprandial hyperglycemia. So the approach to treatment of type 2 diabetes, it does include, of course, lifestyle. And actually, I would add, I should really put, it's same applied to type 1 and type 2. Yeah, treating hyperglycemia, lifestyle is present every step of the way. Diet, exercise, weight management, cannot emphasize enough of that. But that's kind of lecture on its own. So we are going to today focus more on medications. Medications, of course, can be oral or injectable, including insulin. And really, the new paradigm is the paying attention to also reduction of cardiovascular risk factors, because we know that it is the heart disease that is the #1 cause of death for diabetics, and diabetics have, we already established, high risk of dying from heart disease. So just one slide on lifestyle therapy. This is from the American Association of Clinical Endocrinologists, and kind of talks about what goes into lifestyle. So when you write in your note, recommend lifestyle modification, that includes nutrition, physical activity, paying attention to sleep hygiene, discovering patients with sleep apnea, which, by the way, large percent of definitely obese diabetics have. So I send a lot of people to Dr. O'Donnell and her team at Georgetown, and they all come inevitably positive for sleep apnea. The discussing the other behavioral issues. I mean, often patients may have either stressor and factors that affect their eating and therefore glucose, and then of course smoking cessation is very important. Just in terms of nutrition, one line, it says avoid fat, as calorie restriction, yes, that is important, but what elevates the blood glucose, we know it's the carbohydrates. So it's really important that in addition to calorie restriction, patient also is on some form of consistent carbohydrate diet and reduces the total number of carbs per day. And if anybody has question at the end, how many carbs should diabetics eat, I'll be happy to answer that. So how do you pick from this vast menu of oral agents now that we have? I mean, 30 years ago when I was a resident, things were much easier because we only had like 3 oral agents. Now we have 30 plus. So we, in addition to lowering blood glucose, we are also looking at the safety profile of that agent and how that matches the patient profile. Expense is not a trivial consideration. And then now we are also trying to choose the agents that, in addition to glucose lowering, have other beneficial effects such as favorable lipid profile, weight reduction, or blood pressure reduction. So here's the menu in a kind of shorter version. There are 12 officially classes of diabetic medications available. I'm not going to read through all of them, but needless to say, it's a pretty big menu. So it's nice that we have a lot of things we can choose from, and therefore it does allow us to truly individualize the management of type 2 diabetes. I want you to show this concept that Dr. DeFranzo, who is one of the famous endocrinologists, introduced about 10 years ago, and it's the Ominous Octet. For some of you that play music, the octet is usually when you have 8, musicians playing together. In this case, it's the 8 different organs contributing to hyperglycemia and glucose management. And this is important to kind of remind us, because often when we say diabetes, people think pancreas, okay, which is fine, but pancreas is just one of the players in this orchestra or a team, if you wish. So pancreas, of course, is responsible for insulin secretion through the beta cells and also glucagon through alpha cells. But don't forget, liver is where the majority of the glucose synthesis occurs, over 2/3. The other 1/3 of glucose comes from kidney. Kidney is also involved in glucose, reabsorption. Muscle involving glucose uptake. That's why when you exercise, that helps lower blood glucose, because now glucose is being taken up by the muscle. Fat is important issue in terms of insulin resistance, the release of free fatty acids and how that affects glucose. Then the intestine turn out to be extremely important because there are hormones there. We'll talk a little more about them. The incretins, GLP, and for example, that regulate the glucose. So, and then the brain, the neurotransmitters in the brain, they talk with some of those organs, including gut. So it truly is the team effort. Okay, so this is again from the ADA, one of those algorithms how to approach the management of type 2 diabetes. we used to carry those laminated cards in the pocket. Now it's all on your smartphones. I mean, it is a good starting point, and I'll just mention a few things. So, for example, the lifestyle modification, diet and exercise, that goes without saying. And then from the onset of diabetes, we are not waiting for, giving patient 3-month lifestyle and then telling them to come back. We used to do that many years ago. Now we are starting metformin right away. So first line treatment, unless there are contraindication, is metformin. If the A1C level is above 9 at the onset of diabetes, then one may consider starting patient immediately on 2 agents. And if A1C is more than 10 and patient is symptomatic, one may need to go straight to insulin, okay? So let's assume A1C is 8 or less, patient started on metformin. 3 months later, if the A1C is not at goal, add the second agent. And the emphasis is do not wait more than 3 months. The studies show that the average physician waits 20 months before adding second agent. That is unacceptable. And what second agent you want to add, really, at the end of the day, is not as important as it is important that you do something, as long as you add the second agent. This is the menu. Sulfonylurea is really falling now into more like a 4th, 5th line. Right now, what is recommended, again, by ADA, by ACE, as a second line, it's either SGLT2 or GLP. They are the top kind of contenders for that second place after metformin. If 2 agents is not enough, one can go to triple therapy. So one can be on either 3 oral agents or maybe 2 oral agents and maybe 1 injectable, that is GLP. Insulin is always out there for you if needed, so don't think of insulin as an absolutely last resort. Okay, so again, similar thing that I said, the first one was by ADA, this one by ACE. They, it's pretty much similar. You will have those slides. You can kind of study at your leisure. I like this slide because just to raise your awareness that we do have now quite a few diabetic agents that also can help with weight loss. And knowing that majority of our type 2 diabetics are overweight or obese, and quite a few type 1 diabetics are overweight or obese, it does help if you can choose the agent that, in addition to glucose lowering, will have a weight loss effect. And just to mention the few, metformin has some minimal weight reduction effect. It's not really big, much bigger with GLP. The SGLT2s definitely have more than metformin, so I would argue it deserves the 2 arrows down. Some of the agents actually can cause weight gain. For example, sulfonylurea. That's one of the big reasons why we should stay away from sulfonylurea. Of course, the other reason to stay away from sulfonylurea is a high incidence of hypoglycemia. Okay, so we already mentioned metformin. Consider first-line treatment for type 2 diabetes, unless there are contraindications. So the metformin, it does not cause hypoglycemia, so it's kind of neutral there. It does have a slight weight loss. We already mentioned that. The main side effect of metformin is the gastrointestinal side effects, but they can be avoided in most people. So I would say about 95% of your patients will be able to tolerate metformin. About 5%, no matter how hard you try, they will complain and they will, they won't take it due to GI side effects. The key with metformin is start low and go slow. So I usually titrate metformin by 500 milligram weekly. So into the new onset, the medication naive, new onset type 2 diabetic, I may start with 500 milligrams of metformin and do that with dinner. Usually it's tolerated better if it's taken with a larger meal. And then I go next week to 500 with breakfast, 500 with dinner. And then the third week, I add the second 500 with dinner. Basically, after 4 weeks, I have brought my patient to really effective dose, therapeutic dose, which is 2,000 milligrams per day. There are some contraindications with metformin and things you do need to know. We used to use creatinine cutoffs for metformin. Now we have adopted using the GFR. If the patient has GFR below 30, you should not use metformin. If the GFR is between 45 and 60, one should reduce metformin dose to 1,000 milligrams, and GFR more than 60 patient can be on a maximum dose of 2,000 milligrams. Patient has active congestive heart failure should stay away from metformin. Patient that's undergoing procedure with iodinated contrast, such as, for example, CT, contrast CT, you should stop metformin before and for 24 hours after. And clearly, you know, patient that it's acidotic because metformin can cause lactic acidosis. However, the incidence of lactic acidosis is extremely rare. Okay, so that's enough about metformin. Let's talk about DPP-4 inhibitors. So the DPP-4 inhibitors used to be a commonly second-line treatment after metformin. And I say used to because, as I already told you, now we gravitate more toward SGLT2 and GLP. And when we talk about those drugs, it will be clear why. But the DPP-4 inhibitors are the drugs that block the enzyme that degrades incretins. Therefore, the body then now has more incretins on board, and more incretins means more insulin and less glucagon and lower the blood glucose. Medication in this class, there are at least 4 of them. I listed them here. Those agents have a modest A1C lowering effect, about 0.8%. They are usually well tolerated, rarely some respiratory infection, but they're one of the biggest advantages is that they are well tolerated. However, they do come with the warning that there have been cases of acute pancreatitis, including fatal and non-fatal hemorrhagic necrotizing pancreatitis. So anybody that has history of pancreatitis or has a very high triglyceride level, or, you know, somebody with previous pancreatic tumor, I would not put them on this type of drug. Okay, so let's talk about our GLPs. So the GLPs analog, what they do is they basically promote the potentiate insulin secretions. They lower the glucagon. They slow the gastric emptying. They have also effect on the decreased glucose production in the liver, increased insulin sensitivity in the muscle. So it's a really quite impressive class of drug, and they are becoming now more and more potentially second-line treatment for diabetes. So you are, I'm sure, very familiar with those drugs because they have been around now for at least 15 years. The first GLP that became available was Byetta or exenatide. Now we have about 9 different drugs in this category. They can be given either as a once a day, example would be liraglutide or Victoza, or once a week injection, and that is the exenatide extended release or Bydureon, the dulaglutide or Trulicity, and the one that I use most commonly, semaglutide or Ozempic. And the reason why I use this one most commonly because, again, it has the most weight loss of all the 3 agents. Patients that are very needle phobic and don't want to even see the needle, although those needles are 33 gauge, so they are really, super thin and super short, but the Trulicity does have a pen device where a patient would inject without even seeing a needle. So that may be option for them. And then more recently, last year, we have addition of oral GLP. There is only one right now on the market, and so it's an oral semaglutide. It's called Rybelsus, and that one is given daily versus the injectable semaglutide that it's given weekly. Most patients are on injectable, although the oral seem kind of attractive option at the first glance. It does have to be given at certain time before eating with a certain amount of water. So I think that's one of the downsides. Plus, again, it doesn't cause as much weight loss as injectable. At the end of the day, which GLP you use, again, it may come, unfortunately, down to whatever the insurance approves, because certain insurances have certain preferences, but most of those agents are very similar in terms of the glucose lowering, side effect profile, and everything else. I do want to bring to your attention that the GLP agonists can be also combined with insulin. So we have the pens that have a combination of GLP and insulin. And actually, there are two of them on the market. There is a Zoltify, and then there is a Soliqua. Soliqua is a combination of insulin lantus with lixisenatide. So it's a unique GLP made by Sanofi for this particular pen. And the Zoltify is the combination of degludec or Tresiba with Victoza or liraglutide. So the advantage of those combined GLP insulin pens is that patients that they need basal insulin, but they would benefit from GLP-1, especially because of weight loss. You can, combine this now in one shot, so you are not increasing the number of injections that patient is taking. The main disadvantage is the titration scheme and the maximum, and the dosing, because it's a kind of fixed ratio of GLP to insulin. It's kind of the same issue that we ran with the premix insulins, for example, 70-30, where you have 70% long-acting, 30% short-acting. So there is no flexibility of adjusting each individual component. Okay, so we talk about metformin, we talk about DPP-4s, we talk about GLP. Another important class of diabetic drugs that came out 7 years ago is the SGLT2 inhibitors. So what are the SGLT2? The SGLT2 inhibitors, they block the reabsorption of glucose. So normally what happens, as the glucose gets excreted through the glomerulus, goes in the proximal tubule, 90% of glucose is reabsorbed in a proximal tubule. Only small amount makes it more distally, about 10%. There are SGLT2 transporters in the proximal tubules that allow this process of glucose reabsorption. If the patient is diabetic, you don't want them to be reabsorbing glucose, right? You want them to excrete the glucose in the urine to get rid of glucose. So that's exactly what those drugs do. So I like to refer to them as they direct the traffic of glucose in the proximal tubule. They are blocking the glucose from going back into circulation, and they are dumping the glucose in the urine, causing glycosuria. Loss of glucose in the urine, of course, that promotes the urination because glucose and water travel together. Loss of glucose in the urine also translates into loss of calories. And you should know that 1 gram of glucose equals 4 calories. The average amount of glucose that it's lost per day on SGLT2 inhibitors is anywhere from 60 to 100 grams. So if for example, if the patient loses the 100 grams of glucose per day in the urine, that is 400 calories. 400 calories equals pretty decent 1 hour exercise on a treadmill. Please do not tell your patients this. I don't want them to just take this drug and then abandon their exercise. Okay, so what are some downsides to SGLT2? Well, you may have heard, or maybe I don't know if you had a patient that develops diabetic ketoacidosis. That is very rare for type 2s. Some physicians have tried using those drugs for type 1 diabetes. That is not FDA approved, although it's an attractive option. It has been studied and actually was even brought to FDA for approval, and they turn it down because of the risk of diabetic ketoacidosis in type 1 primarily. The most common side effects seen in clinical study is a yeast infection, and those are the genital tract yeast infections, so not systemic yeast infection. Purnia gangrene, extremely rare. Commonly, yes, there may be volume depletion if patient doesn't drink enough, so they have to stay hydrated. The canagliflozin has a FDA black box warning for amputation that was seen in their initial study, not confirmed with later larger study, but still it is there as a warning. So if somebody has already severe peripheral vascular disease, venous insufficiency, already had toes amputated, probably would stay away from this class in general. That's just my opinion. So some of the drugs in this class, again, I listed the menu here. And I will say a few words about Invokana or canagliflozin, because that was the first SGLT2 that came out in 2013. Since then, several more came. They are all indicated as an adjunct to diet and exercise for treatment of type 2 diabetes. With Invokana, starting dose is 100 milligram once daily, as long as the GFR is above 45. And if the patient is not at goal on 100, and if the GFR is more than 60, the dose can be increased to 300 milligrams. So all those SGLT2 drugs, they have a different dosing for different GFR threshold. The average A1C lowering, little more than DPP-4, anywhere from 0.77 to about 1%. They do cause weight and blood pressure reduction, and that was the first class of the oral diabetic drugs ever to show both improvement in weight, blood pressure, in addition to glucose lowering. Jardiance, Farxiga, I put the dosing and GFR thresholds there for you to review. So just check on this when you are prescribing those drugs. So one of the big things that came out after the SGLT2s were approved is their cardiovascular outcome data study, and Jardiance or empagliflozin was the first one that had cardiovascular outcome study. When Jardiance was added to standard of care in patients with type 2 diabetes, it had a significant reduction in cardiovascular events, cardiovascular death, mortality, as well as reduction in hospitalization for heart failure. So very soon this class of drug became favorite not just among endocrinologists, but also among cardiologists. So this is, if anybody is interested more in cardiovascular outcomes, this is just a little, it was a really good review article, and basically, sorry, must be talking too much. In a nutshell, most of the SGLT2 inhibitors as well as GLP receptor agonists have shown cardiovascular disease reduction, as well as SGLT2s have shown a decrease in progression of diabetes kidney disease, and then SGLT2s have also shown to reduce risk of hospitalization for patients with heart failure. So when considering treatment of type 2 diabetes, knowing that majority of diabetics have either established cardiovascular disease, diabetic kidney disease, or at high risk and have multiple risk factors for those conditions, it really makes sense now you understand better why we consider SGLT2 and GLP as a second-line treatment after metformin. Okay, and that's really all emphasized here. So because of time, I'm just going to skip through that. So we have a few minutes for insulin. Insulin is most powerful agent to control blood glucose. Ideally, insulin should be peakless, cause less hypoglycemia, and that is all those newer insulins that we have right now compared to some older ones we had 30 years ago. Insulin is, of course, really the main treatment for type 1 diabetes. So everything we talked so far, in terms of management applies to type 2. Insulin is still the absolutely necessary for all type 1 diabetics. Insulin can be delivered in different devices. So please remember that, because I still see quite a few patients using syringes and needles, and that is not necessary. And it's not true that it's cheaper. For most patients, pen is not going to be necessarily more expensive, and definitely has multiple advantages, including the fact that the pen does not need to be refrigerated. So if you are diabetic and work in a hospital, you could be also having this pen in your pocket, and maybe you give yourself insulin now while you are eating your lunch and listening to my lecture. You can be in a restaurant, give yourself insulin, and nobody would even notice. So, and then pens are also much more precise because they can dial by 1 unit, even a 0.5 unit. Okay, so we already talked a little bit about when to add insulin. There is no clear consensus of this. Definitely, some people say if the A1C is more than 8 or more than 9. And after patient has already been on oral agents, including GLP and SGLT2, and they are not reaching the glycemic goal, how do you start with insulin, and where do you start? But we usually start with the basal insulin and start with as a total daily dose anywhere. If you want to be very conservative, 0.1 or 0.2 units per kilogram, or for obese patients or more hyperglycemic, you can go 0.2 to 0.3. So for your typical, let's say, 200 pounds patient, or 100 kilogram, for 100 kilogram patients, starting dose can be anywhere from 10 to 20 units of long-acting insulin. I would say for all my 200 pounds or more patients, I would start at the minimum 20 units of a long-acting insulin. If they are a type 1, or if they are more slim, type 2, I may start 10 to 15 units. And then you titrate every 2 to 3 days based on the fasting blood glucose. The concept of basal bolus, I'm sure most of you are familiar. Unfortunately, there is no one insulin shot that can provide continuous glucose coverage, as well as glucose lowering, as well as prevent the spikes in glucose after eating. So the basal insulin controls glucose in between meals, and then we have meal or prandial insulin that's given before each meal to prevent the spike that comes from eating. And that is shown here. So you want that basal to be flat 24 hours, and then you want your short-acting insulin to be very quick on and off, matching the peak of blood glucose that occurs after eating. So here is the menu of different insulins that we have. We have at least 3 rapid acting, and now we have some generic as well. So the Aspart is Novolog, Glulisine is Apidra, Lispro is Humalog, and then we have Admelog, which is the generic Lispro. And we have also Fiasp, which is a little different, which is also Aspart, but Aspart on steroids, so to speak, so it acts even faster. So this whole class of rapid-acting insulin is a quick 15 minutes or so onset of action. Peak is in 1 to 2 hours, and pretty much most of the duration of action is about 4 hours. And compare that to your old-fashioned regular insulin, when patient had to take that insulin at least 30 minutes before eating, and regular insulin will last, 6 to 10 hours. sorry, 0 missing there, 6 to 10. The MPH is sort of intermediate insulin, usually given twice a day. We don't use it as much. So most of your patients will be on that are on basal bolus therapy will be on one of those rapid-acting insulins, and then they will be on basal insulin of either glargine or Lantus, Basaglar, which is biosimilar or generic glargine. Then Toujeo is the glargine U300, that's a more concentrated glargine. Then we have Detamir or Levemir, which is sort of not exactly 24-hour insulin, it's more like 16 to 18. Then we have Degludec or Tresiba that actually lasts even longer than 24 hours, although it's only dosed once a day. And then don't forget, we have this unique Humalog U500 insulin, which is the 5-time more concentrated insulin. And it's used primarily for patients with severe insulin resistance and obesity. And we actually don't carry that in a hospital due to high risk of medical error. Okay, so how often should patients check their glucose? If they are not on insulin, they can check at least once a day at different times. Please don't have your patient always check fasting blood glucose, because then after 3 months, all they have is the fasting data. And if their postprandials are high, they come to see you, A1C is high, you tell them they are not doing well, and they look at you and say, well, excuse me, all my fastings are in a good range. So if they are checking once a day, they should vary the time where they check. Patients on insulin should check at the minimum as many times as the insulin injection. So if they are on 4 shots, they should check 4 times a day. If they are on 3 shots, 3 times a day. In the last remaining couple of minutes, I want to bring you up to date with some newer insulin technology. Of course, insulin pumps, they've been around for a while, but they are getting better and fancier and smarter. And we have the traditional pumps that have tubing, and then we have this one, like a patch pump. It's called Omnipod, and it's literally like a little patch patient wears for 3 days. They peel it off, they dispose it, and they put new one. So it's a disposable every 3 days insulin pump, and they get a little PDM, the remote device that they use to operate the pump. What has been the most exciting and revolutionary is this continuous glucose monitors, the CGMs. This is the example of the leader in that field, and that is the Dexcom. It's a little sensor. The patient, again, it's attached to their body, replaces every 14 days, and then they can monitor their glucose data either on a little receiver if they choose to, or most patients will monitor their glucose on their phones or actually on the Apple Watch as well. And not just that, the patient can monitor their glucose data on the phone. Up to 3 or 4 different people can monitor at the same time. So if you have a child, both parents can be monitoring, or I have some older patients where their children are monitoring their elderly parents' blood glucose. And the continuous glucose monitor, the Dexcom, can talk to several different devices. It can be worn together with the Dexcom pump, the Omnipod pump. It's also integrated with one of the insulin pumps called Tandem T Slim pump. And there are some smart pens also that get the feedback from the Dexcom as well. Another sensor beside Dexcom for, just to not forget, is Freestyle Libre. And for some of you, probably in your internal medicine clinic, maybe you have seen especially type 2 diabetics on this. So Freestyle Libre is also a little patch sensor the patient replaced every 14 days. It does provide the similar data. The main difference is that the Dexcom has alarms. It alarms the patient when glucose goes up and goes down. Libre, it does not have alarm. Patients need to be actively scanning to see the glucose versus Dexcom, where the data is continuously fed to them. And this is the example of the report that we get from Dexcom. So there are about actually 9 different reports, I believe, that can be generated. And so before seeing me, patients usually go through patient portals, send their Dexcom reports for us so we can review them. And then that helps us adjust the therapy. And those reports will give you average blood glucose. They give standard deviation, the range of low, high, the percent in target. I mean, there is a lot of good data that can be extracted from those reports. Some of you may have heard also of this, artificial, sort of, artificial pancreas in terms of closed loop system where the sensor talks to the pump. And then when the glucose is going down, the pump stops insulin delivery. As the glucose goes up, pump restarts insulin delivery. So it's a closed loop system where the pump and sensor are talking to each other. So we have already 2 systems out there. The first one was this one shown here, Medtronic, and there is another one now with T-Slim. So most of my type 1 diabetics are using this. I mean, that is the closest they can get short of having, a pancreas transplant. So I will stop here. I think time is up. Managing diabetes is a complex, it's a team approach. And in addition to physicians, we do need our educators, dietitian, pharmacists,